Hello, and welcome to the Neurology Nuts and Bolts podcast, a podcast about constructing your career in neurology. I'm your host, Dr. Kathryn Moore. I'm an assistant professor of neurology and movement disorder specialist at Duke University in North Carolina. Today on the podcast, we're so pleased to have Dr. Joel Morgenlander to discuss the role of advanced practice providers in neurology. Dr. Morgenlander is a professor of neurology at the Duke University School of Medicine. He completed medical school at the University of Pittsburgh Medical Center and his neurology residency and neuromuscular fellowship at Duke University. Since that time, he has served at Duke in a variety of roles, and notably for this discussion, developed a residency program in neurology for advanced practice providers. So welcome to Dr. Morgenlander.
Thank you. Glad to be here.
You know, one thing we can all agree on is that APPs are becoming increasingly integrated into healthcare, and both on the inpatient and the outpatient side of practice. So in this episode, we aim to go into details on working with APPs as members of the healthcare teams. First off, can you tell us what is an APP?
So advanced practice providers, or APPs, it's a term we use for nurse practitioners or physician assistants. And as you likely know, the training for those two groups is a little bit different. Physician assistants are folks that have had some kind of clinical exposure prior to going to their physician assistant program, and then they attend a 2-year program that was patterned somewhat after medical school, in that they have a year of lectures and then a year of clinical rotations that are primarily centered on primary care type topics like medicine, surgery, pediatrics, OB-GYN, that kind of thing. They are free to get licenses and go into practice after that, after their certifying exam, or some of the physician's assistants get further training before they practice. Nurse practitioners are folks who were nurses first, so they have a lot of clinical exposure by being nurses, but then to do a master's level program that involves further didactic work and then some clinical hours, although their clinical hours are less than what usually a physician's assistant will get in school. And then when they're done, they take a certifying exam and they are free to practice as nurse practitioners in whatever area they want to practice. Once again, the nurse practitioner training is a little different in that they a priori pick an area of concentration, such as pediatrics, family practice, critical care, and then likely would go into some offshoot of that primary area of concentration.
If I'm understanding you correctly, then a nurse practitioner would pick an area and stay with that for the duration of their career, but can PAs switch from one area to another?
So in fact, both advanced practice provider groups can switch between areas. You know, much like with medical training, there's a substantial percentage of advanced practice providers that have a specific area in medicine of primary interest to them, either through personal experience or professional experience in the past, and tend to focus in one area. So when they switch jobs, they tend to switch jobs to other locations that are doing similar kinds of medical practice, but that doesn't have to be the case. And there's nothing, you know, I, as a neurologist that wanted to switch jobs, and let's say I wanted to become a pediatrician, there'd be a lot of people looking cross-eyed at me. An advanced practice provider that was working in neurology and decided they'd actually like to work in pediatrics, I think people would look less cross-eyed at them, but they'd wonder, well, what is your experience to prepare you for practicing in pediatrics? And that might be a limitation to them making the switch. More commonly, you'd see like a neurology advanced practice provider go work in neurology or neuroscience in some way somewhere else, as opposed to pick sort of a different area to work in.
So it sounds like they have a little bit more flexibility, but it would still be in a related area if they're switching their working conditions.
Usually that's what I've found people do.
Mm-hmm. And so in day-to-day practice, are both types of APPs fairly similar?
From my perspective and how we use APPs in neurology, their final job description may be identical. We have a neurology residency program for APPs at Duke. We accept both physician's assistants and nurse practitioners in the program. They come with different knowledge bases and strengths and weaknesses, but their common final training in our residency program is identical, and the jobs that they would assume within the neurology department are in general identical. The much like there didn't used to be neurology residencies, right? There used to be a bunch of internal medicine doctors that took care of all of neurology. And then the knowledge base in neurology grew so much that it made sense for people to spend their time focused on the area of neurology. And we created neurology residency programs in the United States. And then because the subspecialty of neurology grew so much, there became subspecialties, and it made sense for bright, interested people like yourself to become subspecialists and do a fellowship. We've grown up in our educational system in medicine to figure out ways to not only grow the knowledge base and the expertise of the clinicians, but hopefully those aspects best serve our patients. So I think a similar evolution is going on in the advanced practice world, where if you go way back, people graduated their program and went into practice and learned their skills and their subspecialties on the fly. It's abundantly clear to us that while there's a lot of great training, particularly related to primary care issues in NP and PA school, folks may not be the best prepared for a focused career within neurology. And it may benefit them to take a little bit more time and spend some time, expanding their education to better prepare, not only for clinical care, but, on the academic side, a lot of our APPs teach, a lot of our APPs do clinical research. So there's a whole lot of opportunities available within different subspecialties for practice, education, and research. And it's pretty hard to sort of navigate that when maybe the best you could have done was a 1-month rotation in neurology during your training program.
I mean, that makes sense to me. I think we would all agree, for those listeners who have gone through residency training or who are going through it, you learn so much in your residency, even, we're talking about APPs, but as physicians here, that there's no way you could go without doing that and go right into practice.
Yeah, and I think that, because these programs weren't available, we have a generation of very experienced APPs who are very talented. And they had to figure it out between the people they work with and taking CME and doing other educational activities on how they're going to best care for their patients and practice. So it's not to discredit, experience as a teacher. Experience Certainly. Is wonderful. And but neurology, has its own unique mindset, and how we approach patients, and particularly how we take a step back on localized lesions and formulate cases and try and figure through things that, it takes a lot of practice. It takes seeing a lot of patients, putting yourself on the spot, going through the processes. And it's really nice to be able to learn that process when you might not be the person who's personally responsible for the outcome of that patient, because you're starting out as a learner and you got somebody to work with to figure it out.
Fair enough. I think we're all adult learners, always hopefully learning new things, but perhaps that protective environment and that structured environment can be really helpful. So what does the additional residency training look like?
Well, I can tell you what ours looks like. I mean, there are other residency programs popping up across the United States, but our training program basically looks a little like a junior year of traditional neurology residency. We have people first working in the clinic. They do month rotations in general neurology and all the neurological subspecialties. We focus early on being able to do a good neurology exam, how to write notes, sort of how to order labs, how to start looking at imaging and neurophysiology tests. And then folks work in individual specialties with mentoring both neurologists and APPs to learn a little bit about those areas of neurology. And then they rotate on our inpatient service, doing inpatient consults, general neurology, and stroke, and learn a bit about inpatient neurology with some time for elective. I think one of the issues with hiring APPs that might not lead to the best fit or the best retention is that, traditionally what would happen if your department or practice believed in the benefits of APPs, you might, for instance, say have a movement disorder job opening, and you hired somebody directly into a movement disorder job who has basically no real experience in neurology. They don't know if they're going to like movement disorders or not. When I went into neurology, I didn't know exactly what I was going to do in neurology, and it was only through rotating through different areas and learning about different types of patients that I figured out what it was I was going to do in neurology. So by having a residency program, we allow those APPs to rotate through the different services and get a sense of what did they particularly like? Did they like outpatient neurology? Did they like inpatient neurology? What kind of job would they like? Because we want, as with anybody on our team, we want them to be happy with their work they're doing every day. We want them to be able to grow. And we've made an investment in them during the residency. We would ideally like to retain them for a bunch of years in our department and take advantage of that investment. So I think we've been fortunate that we've been able to match up people for the most part with areas that they were interested in, and made a good situation where the vast majority of our residents have stayed to work at Duke, and we've had very good retention of those APPs. So that's one of the big advantages, I think. And plus, you know how neurology is. Your movement disorder patient may have a seizure, and we don't necessarily want that APP that sees that patient with a seizure to panic and not understand how to approach that patient with a single seizure. And, might they send them on to an epileptologist eventually? Yeah, they might. But, if it's a relatively straightforward problem, they might also just take care of it themselves, which is nice for the patient because, that APP has a relationship with that patient and can probably expedite the workup much faster than if you now have to get in another loop waiting for another doctor.
Sure.
So we want people to be comfortable doing what might happen in the longitudinal care of patients, which, in many of our areas, we're not seeing somebody once, we're seeing them possibly for the rest of their lives in our clinics. So stuff's going to happen. And even if we don't handle it ourselves, I mean, we understand from the training, like who's the right person or right group to plug this person into to get them the best care, and what can I order now that will help my colleague be further ahead when they see them. Otherwise, you might not know what to order, not feel like you can prescribe to bridge that gap, and it's not the ideal situation for the patient.
Right. So it equips them to recognize the problem and then start off the right path. Exactly. To either deal with it themselves or certainly make wise decisions about referrals.
Exactly.
What's interesting to me is that for us, you have to go through residency, and here it's something they're seeking out for additional training and comfort level, but they have the flexibility to still practice without that. Is that right?
Yeah, I mean, we're big advocates on team-based care. As you may be aware, there is a lot of political debate about whether advanced practice providers should be able to practice independently. I have a lot of confidence in our advanced practice providers, and they do see both new and return patients. However, they're part of a system, so that, for instance, I had an email when I got back to my office today to speak to you from one of my APPs saying, I saw this complicated patient. I really want to run it by you. Do you have time later today so we can talk? So it really facilitates being able to have those conversations because it's an order of magnitude more experience that we have as physicians, subspecialists. And sometimes, when something's particularly complicated, you need that extra experience to figure out how to navigate it. So I think, as teams, that's a huge plus. Plus, from my standpoint, as with many neurology practices, our wait times for a new patient may be out months. And if I'm personally seeing all my return patients myself, that's just going to make my wait times even worse. If I have capable colleagues that we can work as a team so that we can share patients, and sometimes they're going to see my APP and sometimes they're going to see me, that allows me to change my template and schedule more new patients so that we can greatly improve our access problems. And then some areas where maybe the neurological evaluation is a little bit more straightforward, headache, memory disorder, sleep, you could imagine that it would be very reasonable for an APP as part of a team to see some new patients as well and be able to be working in concert with neurologists who are available to be involved in the care and be partners with the APP. So it's really been a positive. I can tell you on the inpatient service, we've been able to not only increase our capacity to take care of neurology patients by having APPs on the team, but in an academic setting, one of the difficult parts is, our physicians and our residents rotate on and off, and their ability to develop beneficial relationships with the other staff on the floor, the clerks, the nurses, the therapists, the discharge folks, is very hampered by that. Whereas when APPs are basically working in a hospitalist model where they're on weeks at a time and switching between each other, they know how everything works. They're the consistency for the team, so that all the other folks working in the hospital that are trying to work on quality initiatives and other things have a team member from our team to work with who understands, what the priorities are, and also a resource for our residents to learn from when they rotate through and have never been on an inpatient service on neurology before, for instance, and they're responsible for all this care. They have somebody that, knows how to order a stat MRI inpatient, get a lumbar puncture done when you weren't able to do it yourself, et cetera, et cetera. So in fact, our APPs routinely on both our stroke and general neurology services get teaching awards from the residents because they're so thankful for the great mentoring and assisting that is done on the service. And I think unlike when I grew up in medicine, we didn't really have much in the way of APPs. I can remember counting on a single hand the number that were at Duke. I think our current resident group grows up understanding more about team-based care and how we work together to take care of a group of patients. I think the last Netscape poll or Medscape poll of neurologists suggested that something like 80% of neurologists in practice work with APP. So this is not any longer a unique relationship. It's just, as you're saying about education, it's sort of the education of the practice of medicine and how do we grow that? How do we learn to be more effective, improve access, maybe improve our research capabilities? We have APPs assisting with clinical research trials where before we just didn't have enough neurologists to see the patients we were trying to run through trials, and that limited the number of trials we could have. Now, when you have, subspecialty APPs seeing patients as part of trials, we can actually, do more high volume quality studies because we have more providers that are available to participate.
So for our residents that are listening, what are some tips that you would give them to work best with APPs and to learn from them? Because I certainly have had that advantage in my training too.
Yeah, I think it's always reasonable if you don't understand what a person's background is to politely ask, I haven't worked with an APP before. Can you tell me, where did you train and, what have you done in neurology before? And, what is your understanding of your expectations on this service? And I'll tell you what my understanding of my expectations are. And hopefully both people understand what their expectations are. And if not, there should be somebody to talk to about that. And just to, give it a chance and see what works, and see how it's worked in the past. And there's always opportunity for improvement, and it might not be so much of what you do relative to the APP. It might be what both of you do relative to something else, and how can we work together to make our practice environments better. So there's always opportunities to make practice environments better. And I think, it's nice to have dedicated people to that group of patients or that unit or that clinic to be able to work on it. And a lot of times the APPs, they just have a great perspective, because they're not necessarily, the ones that are working there are not rotating between locations.
Mm-hmm.
I mean, just have a dialogue, be open, be friendly, try and make each other better. That's what we're all trying to do. So
yeah, it's true no matter of our background.
Yeah, and I think it's, we talk about diversity in a lot of ways. I mean, people have different educational backgrounds, and
right.
To me, training, the thing that matters most about training is the final common pathway. What did they do last that made them prepared for, this job? And that's why for me, if you've been through our APP residency program, I feel like whether you're an NP or EPA, you're really capable of doing a really good job. And that precise designation becomes much less important to me.
I think that's fair. We've talked a lot about the advantages of working with APPs and how much they can help our learners and clinical care. What are some of the challenges in working with APPs?
Well, I mean, from my standpoint, as somebody that's trying to be an advocate and trying to lead a residency program for them, I didn't fully understand the complexity of their license. So physician's assistants are licensed through the medical board, the same board that we're licensed through, but the nurse practitioners are licensed through the nursing board. And so that creates some other issues, because their CME a lot of times has to be dedicated to their primary area of licensure, whether that's family nurse practitioner, peds, whatever. And, it creates a little bit of a frustration, because you have a nurse practitioner that's working all in neurology. They want to do CME in neurology, but they might need to do CME in another area and pass a different test that may or may not have a lot to do with neurology. So, I think that's an area for us to work on as an educational group. How might we work with nursing boards to allow nurse practitioners to focus their CME on the area they're actually working, and even maybe they're recredentialing in that area. Unlike medical residents, there is no training license for APPs. So one of the other issues for us is that we have to credential our APP residents as a provider and then treat them like residents. Well, if you're running a residency program and you're in a health system and somebody feels like they could get those people to pay for themselves, there's going to be a certain pressure to have them see patients and bill for it. Of course, I'm trying to treat them like learners, which means somebody else should be billing for it, because they're not responsible. If they knew how to be responsible, we wouldn't need residency programs. So there's a certain amount. Luckily at Duke, people have been very sympathetic to that approach, and people have worked with me on that in a positive way. But there are pressures, of course, in everything medicine that's financial, that how are we going to pay for these folks?
What are some of the key things that physicians should be aware of in terms of licensure and liability if you are the supervising physician?
Yeah, I mean, I think it's good to have experienced APPs in your system to advise you. I mean, I think much like we have administrators that are physicians that look out for our credentialing. You want people that are experienced APPs to understand some of these issues around APP credentialing to help you in your practice. And usually there's a senior person that's interested in helping with onboarding. APP's relationships with their physicians and their patients are slightly different. They have different stresses. It's nice to be able to have somebody participate in that mentoring that's a sort of an apples and apples thing, so they kind of know what they're going to have to go through and can work with them as well. I mean, it's nice for them to have physician mentors as well, but I think it helps to have complementary administrative leadership within the APP.
And you were saying how their licensure is with the various boards. So I imagine there's different things from state to state, same as for us.
Particularly for the nurse practitioners, the nursing boards are individual by state. The physician licensure is a national organization that they take, a national test. But for the nursing boards, it's a little bit different.
And we've talked a little bit about how you would think about dividing patient care responsibilities with APPs. Are there certain models that you've seen work or not work? Sounds like it may be different based on the subspecialty.
Well, I think it's like even with neurologists, I think that if you're new out of training, it's a little hard to see a lot of patients in a day. You need a little more time to do what it is you do, and APPs are the same. They can't just, somebody retires or moves away and they've been working with you for 5 years, and you have somebody right out of training coming into your practice. You can't expect them to see the volume that the person that had been doing it for 5 years knows. And also, it might be a return patient to me, but if they've never seen my patient before, it's not a return patient to them. And I think particularly like if it's a hospital discharge or something that they're seeing where there's a bunch of records they have to review. I mean, you just have to be cognizant of the time that they might need to review that case and see it, and give them, make sure they're busy, but they're not burning out.
And I like what you were saying before about a common pathway where we all want to get good at taking care of patients, to be qualified. And to me, thinking about it in that light, when we're all working together in an office, we all want to be treated with respect and not to be pushed to burnout and different things like that. So treating each other as equal partners in patient care, I think is important.
Absolutely. I mean, I think if you want to really help your APP and you're going to have them see your return patients, like what I do is when I'm seeing my patient that I know I'm going to refer to my APP, I say to the patient, it's great seeing you today. I just wanted to let you know that I'm going to be referring you to so-and-so, my APP, who will be trained in our program and is very well suited to help me care for you. You're going to be cared for by both of us. If they have you develop an acute problem that they recognize, they'll be sure to share it with me, but you'll be seeing both of us going forward. And I think when you prep people in that way, they usually do pretty well. And also my experience with referring physicians has been, if you say, well, you can have your patient see a neurologist in 5 months, or you can have them see my APP in 2 months, almost nobody will blink at seeing the APP in 2 months. Because if they end up needing to see the neurologist, there's an expedited pathway to that, and they just want to get help with their patient and get their patient seen.
As we're wrapping up here, any final words you'd like to share with our listeners about working with APPs?
Well, I would just say that, I think it's a huge benefit to have APPs in your practice, whether that be an inpatient or outpatient practice. And it's all about the relationships you build with them and working as a team to try to make sure that, much like if I see a difficult patient, I'll grab one of my colleagues and, have sent you emails, Dr. Moore, to ask about, what do you think about this or that? They need the support and the ability to come talk to their supervising physicians without feeling like there's any barrier or wall between having that communication, so that they can feel comfortable that they can, do the kind of work you're hoping they'll do for you, but also know when they need help, it's not a big deal to come ask for it and get it quickly. And I think it's remarkably improved our practice. Our patient access is better. We have even data on the supervising physicians to show that their burnout is less working with APPs that are trained and excellent in supporting their practice. So I think it's really a win-win. It just, as with every other relationship, takes a little attending to.
Well, thank you so much for your time. I think hopefully this has cleared up questions that people have as they're going through their training and thinking about what style of practice they want to have moving forward. So thank you so much for your time. We really appreciate having you on the podcast.
Yeah, thank you for asking me. Have a great day.
Neurology Nuts and Bolts podcast was created and produced by Sarah Schaefer. It is not recorded as an official podcast of any institution or organization. The podcast is unfunded. Opinions are those of the individual participants. Music by Audrey Nath. Artwork by Shivani Ghoshal. Want more content like this? Be sure to subscribe to the Neurology Nuts and Bolts podcast on all podcast platforms to hear more about constructing your career in neurology. Follow us on Twitter at @NeuroBolts and on Facebook at Neurology Nuts and Bolts to stay up to date on new content and give us feedback on what you want to hear. Tell your friends. Thanks for joining us.